presentation on approach to post-pneumonectomy bronchopleural fistula. Its incidences, what literature say, what are the risk factors, what are the acute measures that we have to take care of, how can we prevent it, and different modalities of treatment will be discussed briefly in this presentation. So I am Dr. Moez, NBMS subspecialty surgical oncology resident here in BPF. So starting with the introduction, bronchopleural fistula is simply defined as the communication between the bronchus and pleural space, which result in accumulation of air in the pleural cavity. So there are different literature giving incidences of post-pneumonectomy bronchopleural fistula as well as bronchopleural fistulas associated with other lung resection. So as per the report from Sarfolio in 2001, pneumonectomy resulted in about 8.6% of the cases of bronchopleural fistula. So what I mean is bronchopleural fistula occurred in about 8.6% of the post-pneumonectomy patients. So the incidence has been varying in different literature, and in recent literature we can see the post-pneumonectomy bronchopleural fistula to occur in about 6%, while lesser resection results in lesser incidences of bronchopleural fistula. There are specific risk factors like surgery on the right side. Pneumonectomy on the right side results in a higher incidences of post-pneumonectomy bronchopleural fistula, as the length of the bronchus is longer. So since the longer stump results in a longer area, devascularized area of the bronchus, which results in delayed healing or defective in the healing, which result in.
How do you say the right main bronchus is longer than the left? You said that the right sided BPF is common because the length of the right main bronchus is longer, whereas the left main bronchus is about 4 to 6 centimeters length, right bronchus is about 2 centimeters length. So how it comes?
So what I mean to say is the stump that is exposed to the air would be longer in the right, as the stump of the left bronchus.
It means the literature is meant to say that when for any reason you are leaving behind a longer stump from the carina, for example, that happens usually in the left side main bronchus is longer, so if a staple and remaining stump from the carina is longer, like 2 centimeters, 3 centimeters, it's bad. That will lead to the bronchopleural fistula. If we were talking about the right side, if we are flushly cutting at the level of origin of right upper lobe bronchus, then there is remaining stump of 2 centimeters, right? So that is also wrong. So we should try to cut the bronchus at the flush at the level of just below the carina, the level of carina. So that they mean to say remaining longer stump should not be there, because there will be a stagnant collection of some secretion, etc. that may lead to the secondary infection, and that may lead to the adhesions of the bronchial stump within the region.
So we have to be careful in patients who have received radiotherapy or chemotherapy, as there may be delayed healing. Patient with diabetes, positive tumor margins, and prolonged mechanical ventilation can increase the risk of developing bronchopleural fistula. So this is a substantially risky condition, as there is mortality rates are reported to be 20 to 71%, and basically these are associated with sepsis, aspiration pneumonia, ARDS, and malnutrition. So bronchopleural fistula can be classified as per different categories, like what the tissue is involved, and how severe it is as per the intensity, and also at the timing of the bronchopleural fistula, as some literatures classify these as early if it happens before 30 post-operative day, and late if it happens after 30 post-operative day. But we can see in literature early are also indicated as some of the cases which occur in the first week post-operatively, and intermediate which occur after the first week and before the 30 days, and late bronchopleural fistula which occur post 30 days post-operatively. So more aggressive strategies are needed in early bronchopleural fistula, as these can be associated with technique of surgery, the defect in the closure of the stump, and other things as well. How do these patients present? It depends on how severe the condition is. As I talked earlier, the grade can be classified as per the Sarfolio classification, and 4 grades, in which the grade 1 indicates presence of bubbling of the air through the drain during forced expiration only, like when the patient is asked to cough. In grade 2, it is during expiration only. In grade 3, it is when the patient is inspiring air, and in grade 4, it is continuous. Bubbling can be seen in the air leak chamber during both inspiration and expiration. So, patient can present with fever, raised WBC, the drop in air fluid level in the post-pneumonectomy space in patient with pneumonectomy. There is increased subcutaneous emphysema. Patient may start to have a develop cough, or they may even cough up bloody fluid, that is the fluid present in the post-pneumonectomy space. Patient may also present with acute respiratory failure, while the patient with late onset bronchopleural fistula can develop a general malaise, loss of appetite, and a general feeling of unwell. It can also be diagnosed or seen in as pneumothorax or pneumopericardium in chest X-ray or CT scan, or when the patient is asymptomatic but a fistula is demonstrated incidentally in the CT scan. So how do we evaluate? There are basically 2 categories of evaluation we can say. It can be either qualitative, just to know whether there is a bronchopleural fistula or not, and clinically grade them, and we can have a quantitative measurement as well. In qualitative, we can use the chest X-ray, CT scan, and bronchoscopy to evaluate the site and size of the bronchopleural fistula, and the grading can be seen, and it can be graded according to the Sarfolio classification by looking at how much air leak can be seen in the chest drain. So in bronchoscopy, in chest X-ray, we can see. I'm sorry, the image has overlapped. We can see the change in air fluid level in the post-pneumonectomy space. Also, there may be the change of the shift of the mediastinum. In CT scan, we might even find the areas of fistula, but not always. In bronchoscopy, we can see bubbling of air in the stump. So in this image, we can see the right main stump, the right main bronchosystem showing bubbling of the air, which can indicate the possibility of leak. Or we can have a quantitative measurement, like either with the analog chest air leak measurement, or we can use a digital system. So this is the Atmos system, which is portable as a battery backup, and the patient can carry this with themselves, and it can log how much air leak was present, and how much air leak the rate, and also the amount can be calculated here. And this is the analog air leak meter. Here are the 7 levels, and the increasing amount of air leak would cause bubbling of the higher level of measurement. So now coming to management, the first and foremost thing that we should keep in our mind is to prevent possible air leak and bronchopleural fistula. So we need to give special attention to the patient who has received neoadjuvant therapy, and also on the right side, as the increased there is the increased exposure of the bronchial stump, while in the left side the bronchial stump is also covered by the aortic arches. We have to make sure we keep a short bronchial stump. Gentle manipulation of airway and avoid devascularization of the remaining stump is mandatory. Routine bronchial reinforcement can be done in this patient. Some authors like to use the pericardial fat pad, as due to the proximity of the pericardial fat pad to the bronchial stump. We can also use intercostal muscle or other muscles like serratus, diaphragm muscle flap, even the pericardial and azygous vein flap also are used. Sometimes omental flap can give us a very good result. and we have to secure the closure of the thoracotomy wound, as this might later confuse us whether the bronchopleural fistula came first or the empyema came first. So we have to make sure of these things. So what are the acute issues and initial management in patient with the bronchopleural fistula? So basically the patient may have empyema at the time of diagnosis of the bronchopleural fistula. So we have to make sure the patient is not having a tension pneumothorax, and we have to manage sepsis with a chest tube drainage. We have to make sure the position of the patient also, as the fistula can result in drowning of the contralateral lung with the content of the pneumonectomy spaces fluid, and we have to send microbiology specimens samples, and nursing care should be done with the operative side down, lower than the normal side, so it prevents swelling of the lung, the contralateral lung. IV antibiotics tailored to the culture and sensitivity, and bronchoscopy to assess the magnitude of fistula. So coming to surgical management, the aim is to drain the infective content, that is empyema, drainage, pleural cavity debridement and decortication, which helps in the healing of the and closure of the space, bronchial stump debridement and closure. Early closure and early debridement and closure can result in a better outcome, and packing of the wound and obliteration of the cavity. So these main surgical management can either be done by Claggett procedure, which is a lengthy procedure, time tested. It takes a few weeks to months, and stump management itself is one of the very important part of the surgical management. And Wader's accelerated approach is the one in which the same incision of the thoracotomy is used, the debridement is done, packing of the wound is done, and closure with a negative suction drain is done. So this helps in healing of the wound and cavity earlier as compared to Claggett procedure. So coming to Claggett procedure, the image here shows either we can make open thoracostoma by removing the whole chest wall, part of the chest wall, or we can use the skin flap as in the Elozar procedure and marsupialize this skin flap, making the space that can be used for regular dressing and debridement. So we create an open window thoracotomy, and debridement, curettage and irrigation of the wound is done. Wound is packed with povidone iodine soaked dressing, and we repeat these until a microscopically clean wound bed is seen. This might take weeks to months. We then fill with antibiotic solution and close, and a delayed definitive closure of the chest is done. So technical aspects are either we can use it open or use an H or U-shaped incision as in the Elozar flap. Make this incision in the most dependent portion of the infected space, and we have to place this incision so as to preserve the musculocutaneous flap, and we can marsupialize the skin to pleura. I have the images to be seen later. So these are the example of the intraoperative and postoperative images of the open window thoracostomy. Here you can see the space has been debrided and omentum has been placed, which later granulates with this decreasing amount of the slough can be seen, and this is later closed by a myocutaneous flap. So this is the image of the diagrammatic image of the Elozar flap creation. So we here we can see the lung has been pushed up and collapsed because of the effusion here, and is the diaphragm here. So we use the most dependent area of the space. So we make the incision, we then cut the ribs and enter into the window chest cavity, clean it, and the skin is then inserted. So we can see the skin is tucked inside and marsupialized, so the space can be later debrided and cleaned thoroughly. In Wader accelerated approach is to early empyema and bronchopleural fistula. We use the initial thoracotomy wound as well. An aggressive mechanical debridement is done, packed with antiseptic soaked dressing. Temporary closure of with the chest tube is done, and with the negative pressure, some literature suggests suggesting a vacuum therapy of minus 75 mmHg, and these are to be repeated every 2 to 3 times every 48 hours over an 8-day period. And when clean, we fill with antibiotic solution and close. Now coming to management of bronchial stump, if the stump is longer than 1 centimeter, and if it is possible, we have to shorten it. So primary closure either with the hand sewn, or if length is available, stapler closure can be technically possible. So flap assisted closure is very important, as local muscle flap like the intercostal transposition can be done, or a distal muscle flaps like the latissimus dorsi, pectoralis major, rectus abdominis, serratus anterior, or omental flap, and pericardial or azagous vein flap can be used. So another approach is the transsternal pericardial approach, which is the Aborigines technique. So here we go directly from the sternum, open the pericardium, and we separate the dead vessels, approach the carina, and then divide the stump proximal to the bronchopleural fistula. Another good approach is the sleeve resection of carina, and right-sided approach for a left stump can also be possible, and combined approaches like the cervical mediastinoscopy, right anterior mediastinoscopy, and parasternal thoracoscopic approach can be used as described by various literature. So flap closure for bronchial reinforcement and closure can either be done by local intercostal flap, as I mentioned earlier. So, or a distant flap like the serratus anterior muscle can be released from its attachment, put inside the chest cavity, and used it to close the bronchial stump. We can also use the pectoralis muscle, major muscle, to close the thoracostomy wound window, or we can use latissimus dorsi to close the window. So here we can see the intraoperative diagrams that shows the thoracostomy window being closed by the latissimus dorsi mycutaneous flap. So omental flap can also be done, and these are technically easy, as said by different authors, and it is one of the most reliable for difficult healing situation, especially in post-infection, post-irradiation, and compromised vascularity or airways, and residual species issues. So what we can do is divide the omentum along with the gastroepiphloic artery. So the division can be depend on which side we are going, either going for the right side or the left side. If we are for the right side of the pleural cavity, we can divide it towards the left side, take the omentum all the way along the right gastroepiphloic artery, and then insert it through a defect made in the anterior part of the diaphragm. So we can see the division of the omentum is being done separating from the colon. Then a defect is made in the anterior part of the diaphragm, then dissecting for passing into the chest cavity. We enter the omentum and then place them on the stump, and this helps in healing of the stump. So another last or ultimately the last resort is like thoracoplasty or thoracomyoplasty, in which we take out the ribs so that the whole of the chest wall gets stuck, collapsing the whole space that is missed, and later it heals by controlling the residual volume. So endoscopic management are options in few of the cases. In selected patients, like we can use it to close the fistula, especially which are less than 5 or 8 mm, or the patients which are unfit for surgery, as surgery has got the improved outcome in all of the cases. So we can use either fibrin glue sealant for small leaks, or the tracheobronchial stents can be used, especially when the patient may be requiring mechanical ventilation. So we can use different types of stent. Here we can see this in the type A. We can see the stent with a closed end toward the right bronchus and open it toward the left bronchus, and similarly for the left bronchus, and we can use it with a single opening inside the left bronchus with the closure. And similarly, for upper lobe bronchus, we can have covered stent, which and so on. So there is another device which has been used in ventricular septal defect. This is called the Amplazer device, and this can be used in a few cases as well. So, so summarizing the management, an algorithm can be made. Like first of all, we have to go with the preventive measures so as to prevent the bronchopleural fistula in the first place. If the patient develops empyema and bronchopleural fistula, important first step is to for the chest drainage and IV antibiotics. So if the patient has an early bronchopleural fistula, in selected cases we might go for endoscopic treatment. If it fails, or if the patient may not benefit by endoscopic procedure, we go for stump repair and Werer technique. And if this fails, we can go for claret window. So similarly, if there is a late bronchopleural fistula and patient is unfit, but there is a small defect, we can go for endoscopic management. If the patient is unfit for surgery and large defect is present, we can go for straight for claret window. Or if the patient is fit, we can go for stump revision and Werer technique. And if all these measures fail, then we can go for thoracoplasty. So the straight line indicates the initial step that can be taken, and this dotted line shows the rescue method that can be applied. So what are the take-home messages? Post-pneumonectomy bronchopleural fistula is a seriously life-threatening situation that requires urgent management, and use of preventive strategies in all pneumonectomies is essential, but especially in the high risk, we should not be forgetting these things. Initial management includes the chest tube drainage, IV antibiotic to manage acute situations, and diagnosis can be done clinically, bronchoscopy, and with the help of CT scan. Surgical procedure mainly are the Clagett and Weber procedure to manage acutely and control sepsis and achieve a cavity sterilization, and an ultimate closure can be used. Fistula closure techniques depend on timing and case-specific consideration, and Weber procedure is preferred as it is more expeditious management, less morbidity and cost, and also better for the patient. Thank you.
Thank you, Dr. Mahesh. It was a wonderful presentation. So very concise, very comprehensive. I have a few questions just to clarify. You said that right-sided pneumonectomy has the higher incidence of post-pneumonectomy BPF. Why? Can things?
Well, as per literature, they
What's the
it
incidence?
is
You said that common incidence rises from 6 to 10 to the 6%. So for right-sided, how much is the incidence? For left-sided,
for right side it is about 6 to 8%, and in left side it is about 2%.
So the right side rises up to 12%.
12%.
The left side is incorrect. What's the reason?
One of the main reasons that was mentioned is the left side bronchial stump is usually under the arch of aorta, so it helps in covering the part of the
Somehow the well vascular tissue is there that protects from stasis. One reason.
Another is for right side to be more is it is exposed, and also
There is nothing
well,
to
cover
in
the
the
yes,
left
yes.
side, and it gets hidden inside the aortic right side. Next, very important. The anatomical issue is that right side. No. Second, that I think Sandeep wanted to say is generally the diameter fragment is large to the left. It is said that anatomically it is more than 25 millimeter in diameter. It has a higher chances of the leakage than this smaller diameter. So we generally comparing the right side has got the bigger diameter than the left side. So there is the higher chance of the leakage in the right side. If any diameter more than 25 millimeter may cause some lesions. And very important that we have missed is the presence of the bronchial artery. If you remember, in the right side there is one bronchial artery. In the left side there are generally two bronchial arteries. So this is very important. So what happens during the pneumonectomy? All the bronchial arteries are gone. But in the left side, since we have got the two bronchial arteries, there is the probability the ischemia is lesser degree to happen there. So that is one of the next reasons for the dehiscence. Therefore, the take-home message from that is, whenever you are considering right pneumonectomy, it's genuine to give some coverage with some flap, viable tissue. One of the most important is either you do with the intercostal flap that you start in the beginning of the thoracotomy, or if you have damaged it, then you can do the pericardial flap. It's very easy to harvest the pericardial fat, pericardial flat flap. You mentioned about the diaphragmatic flap. How would you raise the diaphragmatic flap? Diaphragm is quite low. The main stump bronchus is quite high. So how will you harvest the diaphragm so that it reaches there?
So
will it cause some diaphragmatic dysfunction?
No, we can preserve the phrenic nerve so as to prevent diaphragmatic
How
dysfunction.
important is for the patient after pneumonectomy to preserve the phrenic nerve?
Well, not significantly. We can, if it is damaged, the cavity itself becomes smaller as the eventuation.
What was
of
the
diaphragm.
traditional teaching then?
After
After pneumonectomy, traditional teaching to avoid to minimize the residual cavity. What was the traditional teaching?
we can divide the phrenic nerve.
So the
in
traditional
severe ways.
teaching was either crush the phrenic nerve, Dr. Zaham was telling one time, or you can divide the phrenic nerve so the diaphragm will move upwards, so there will be the lesser amount of the space, residual space, and so lesser chance of the impairment. But I personally think it should not be done unless there are certain situations that patient has got radiation or something, the chest wall compliance is not good, then you can do. Otherwise there is the dysfunction or discoordination between the two hemidiaphragm. So it is not often common, except in certain, when the hemithorax is quite contracted, compliance ठिक छैन for various reasons, एम्पायरमा पहिला भएको थियो के थियो, त्यतिखेर चाहिँ डायफ्रामको मुभमेन्ट कम हुन सक्छ, त्यतिखेर युज गर्न सक्छ, अदरवाइज नट. So there is no benefit. You can just harvest any flap just over the vessel. You are saying that you should not preserve the phrenic nerve in those cases, because you have to take the vascular tissue. So take over the pericardiophrenic vessel and also the phrenic nerve, divide a piece of diaphragm like leaf, then switch off, turn up so that it goes reaches up to the stump. तिमीले बुझ्यौ सौज टाउको हल्लाइरहेको कसरी डायफ्राम बनाउँदा, डायग्राम बनाउँदा कसरी, डायग्राम बनाउँदा कसरी मैले भनेको त्यो त्यही बसेर बनाउने, त्यही बसेर बनाए हुन्छ कागजमा देखाउँ न हैन, मैले के भन्न खोजेको कसरी डायफ्राम त्यहाँ रिच गर्यो. Very good and excellent. So how we can turn up to the bronchus, we can use very well done. So this is the next thing. Then what I was talking about is the right side, why the dehiscence happens more. So it is genuinely that you are considered, basically if after the radiation therapy, then it is very much that you should cover it with some well vascular tissue. Then you said that we connect the after pneumonectomy. What's our practice? Could you connect to the chest portal after surgery or not?
No, not immediately after the surgery. We
So
put
you
a
said
drape,
in
but
your chart, I couldn't understand, make out quite properly. If the patient has the BPF on first post-operative day, would you connect to the chest portal or not? If yes, then how?
If first post-op day, we will go for basically re-exploration.
Re-exploration, right? So if you need to, for the time being, patient, the anesthesia should come, patient has to be taken up to the OT theatre, it will take some time. So is there some way that you can insert the chest tube managed in a different way?
We can have the chest tube, but we can release a very specific amount.
So what we do, we take a Euro bag or some bottle which is closed. So what will happen that the air will drain out and will suck in by itself. So there will be somehow a degree of balance between the positive and negative pressure, but the balloon should be bigger. कि उसको तो air leak भएको भइगयो so that to temporize the management, उसलाई चाहिँ लिएर जान त्यहाँ. Or you can जसरी भनौँ, best approach is that, or to intubate the patient, put the endotracheal tube in the contralateral lung, the healthy lung, so that is only ventilated and that will be taken apart and the patient can be taken to the theatre. Very important thing is, why do you suggest the anesthetist to extubate on table for a pneumonectomy patient? Do you suggest or do you not suggest? Maybe reluctantly you can keep the patient under ventilation for some days.
So if we plan to extubate on the table, then
Not
we'll
plan. We wish
we
to
wish to
extubate. Why? What's
extubate.
the reason behind that?
One thing is we will find out if there is a bronchopleural fistula
No,
or not.
just after surgery, we not find out. We don't know whether the fistula is going to develop or not. But our desire is to extubate the patient on table, specifically for the pneumonectomy. Why? Because the reason a patient, we don't know about the barotrauma, they may induce some sort of PEEP which is contraindicated after post-pneumonectomy. So due to that, it will be the rupture of it will provoke the rupture adhesions of the stump. So whenever possible, extubate on table. If it's for some reason the patient needs intubation, endotracheal ventilation and mechanical ventilation, the request the anesthetist to avoid the PEEP. PEEP should not be given. त्यो पोस्ट न्युमोनेक्टमी पोस्ट न्युमोनेक्टमी कुरो बुझ्दैन त्यो उनीहरूले अब यो कन्सेप्ट क्लियर हुनुपर्छ सो डोन्ट बिलिभ द एनेस्थेटिस्ट वी आर द सर्जन्स हामीले त्यो हिसाबले सोच्छौँ दे डोन्ट टेक अबाउट केयर अबाउट द पोस्ट अफ कम्प्लिकेसन सो यो पनि बुझ्यो होइन सो दिस इज द रिजन नेक्स्ट वाट इज द ही सेड भेरी क्लियरली सौजन तिमीलाई होइन ही सेड भेरी क्लियर देयर आर भेरियस वेज अफ managing the patient. He said about the Clagett procedure. He told about the Wader procedure. He told about the window thoracostomy. He told about the LOCR flap. Okay, idea, sir? Do you know? Okay, sense make out what's up. So what's the difference? 4 things he mentioned out of his the talk. I could not understand. The 4 procedures are recommended when to use what and why it is essential. थाहा छैन सन्दीपलाई के थाहा छ What's the difference between a client? Though he has mentioned in some slide, but technically do you understand that or not? सबै रेस्क्यू जस्तै हो कि भनौँ न The only difference is that Clagett was the first paper from the Clagett himself came into 1985 हो कि 75 1995 हो कि होइन अझै 1965 is very long ago. That was very popular. मलाई थाहा छैन you will have any chance to see this procedure. When I was in Switzerland, I saw a couple of the cases where the Clagett and Wader procedure were done. तर मलाई लाग्दैन तिमीहरूलाई चान्स होला. Have you heard about the laparoscopy? तिमीहरूले देख्दैन होला जिन्दगीमा कहिले पनि जो कि मैले त्यो फेजबाट गुज्रेको छु. When the patient has the fecal peritonitis because the septal hole perforation, then what they used to do, they used to suture a chip in the laboratory. Open garyo, they do the lavage, close the chip, and after 48 hours, 24 again go to the surgery, again open up the chip. त्यो गर्दाखेरि यो सुचर फुचर गर्न परेन नि के लम्फ्राइ गर्नु परेन नि इट्स अ क्विक प्रोसिजर हैन सिमिलरली फ्रम द्याट बेसिस द क्ल्यागेट प्रोसिजर वाज इन्भेन्टेड पहिला गर्दाखेरि के गर्थ्यो त्यो द सिमिलरली दे युज टु ओपन अप द thoracostomy wound just one thoracostomy wound only the skins were closed not the your intercostal muscles they opened they craned it and closed it over the chest then later on the Clagett said it's quite cumbersome it will take time so he made a window then he used to lavage it and pack it and that's it. So different sessions, 48 hours again taken to the patient for the to the theatre, give the general anesthesia and clean and come out. So it was, but it still it was the recommended procedure. Later on the Wader it was from the Zurich, Switzerland के हो त्यो भएर चाहिँ म familiar छु उनीहरूसँग अनि उनीहरूले के गरे a little bit advanced way, not only just cleaning with the doing lavage of the pleural space with the antiseptic solution, but they used to curate it. Curate गर्ने multiple same setup. And back therapy they added, so that will fasten the recovery period. So that was the difference. The procedure was the same, thing was the same. Then come the window thoracostomy only. यसको margin जुन महेशले भन्यो margin suture गरेर not at the depth, only to the edge of the rib incised. And with couple of the ribs were excised, making a window, and then cleaning with the solution, packing their daily dressing, etc. bedside, not on in the operation theatre. Then comes the LOCR flap because it will take months, maybe 6 months, 7 months for complete healing. So that's not good that non-epithelial tissue is there. So therefore he raised the skin myocutaneous flap, divided several, and that was sutured to the pleura. त्यो हुँदाखेरि एउटा open cavity but dressing गर्न सजिलो हुन्छ भने in that concept the LOCR flap was developed. And lastly then the thoracoplasty. So these are the यो steps जो कि हामीहरूले पार गर्नुहुन्छ. Now he missed one thing. He said that the classification is early BPF and the late BPF depending on the time period, right? So in the early BPF we have to classify also, which happens within 7 days, which is from 7 to 30 days. So if it is happening within 7 days, what things you should take into consideration?
So when the bronchopleural fistula is occurring within 7 days, it might indicate some technical fault or there is a chance of the bronchopleural fistula being very large and need acute immediate surgical intervention.
So that's why in those cases, because the first management in any bronchopleural fistula is inserting the chest tube, if it was not inserted in the beginning, or if you have inserted, open it, right, connect to the chest border. So if it is happening in the first, then the mediastinum is not stable. So if you are opening the chest tube, joining the chest border, what will happen? There will be a sudden shift and the patient will die on the spot. So to prevent that, this kind of the patient should be considered for active urgent management. Besides what you have talked about, the antibiotics, etc. So the first assessment should be done by the bronchoscopy to see what is the degree of the dehiscence. If it is quite small, then the endoscopic intervention comes into view. That you said if it's 3 millimeter or sometimes they say up to 5 millimeter, you can insert the glue, fibrin glue, then that will close it. If it is larger, then you have to take the patient for the surgery. Late summon, whatever you have said, there are various other endoscopic methods that you can use. There are early methods. Now, last question would be, if the patient comes in the later stage, after 30 days, you set several choices of the surgical procedures. My specific question, patient comes after left pneumonectomy. After 3 months, he has the empyema with the bronchopleural fistula. You are planning for the surgical approach. How will you approach the patient? You are planning for revision of the stump. The stump was found to be quite long. You are planning to revise it, recut the stump and restructure it and clean the cavity. So what approach will you use? Left-sided pneumonectomy.
In these cases, the first thing would be to drain the infective component by
the approach.
And then for surgical approach, it is possible to go from the right-sided thoracotomy and approach the left bronchial stump and carina.
Very good. When there is the left pneumonectomy, then you can visualize from the right side. Now let's reverse back. The patient has got right pneumonectomy. Would you consider for the left thoracotomy?
Because of the anatomical difficulty, we will approach this from the right side.
No. Now the question is different. When I say, emphasize if the left side pneumonectomy is very well visualized from the right side. Right side, left main bronchus equally about 3 centimeter, you can equally visualize, very well visualize from the right side. But left side, because of the aortic arch, it's very difficult to visualize the right main bronchus. It's mostly impossible to do, not impossible, but it's very difficult, so we don't want to take chance over time. There is another approach there. Then for the left side we have one. Now what will you do for the right side?
For right side we can go for the transsternal.
Good. Sternotomy then, partial sternal split we will go through transsternal, transpericardial. Sternum cardio हटाउँछ, pericardium open गर्यो, aortic arch, vena cava, pulmonary artery. सबैलाई यसरी detach गर्यो, then you will open the posterior layer of the pericardium, then you will see the trachea. त्यसले बुझेछ होला मैले भन्नु. यहाँबाट हैन यो चित्रै बनाएको थिए, यसरी sternotomy गर्यो. Heart is there, pericardium anterior out गर्यो, त्यसपछि now also the aortic arch, vena cava, pulmonary artery. Then retract गर्यो, open the posterior pericardium, then the trachea is the next structure. There you can, whatever you can visualize, you can do. So that procedure can be used both for the right side and also for the left side. So you can omit the thoracotomy in any scenario. Anything you want to add, Dr. Zhang? We're talking about the after pneumonectomy fistula.
We have treatment the one-way,
Valve.
how to say this?
One-way valve.
One-way valve bracket. The air only can this way. This is not. So this bracket is good. You can use the endoscopy and the two-way. Make the bracket correct position. After maybe 1 month, this patient will be good. I remember only one person with reoperation. This patient is likely maybe half a year. We cut for 6, maybe five ribs. Make the chest wall soft and press. Finally, is okay. But this operation is very
Not good.
not good.
Utility.
Yes. Okay, I only this experience.
Thank you. One more thing that adding to Dr. Zhang's point is the some role of rigid bronchoscopy. We said about the endobronchial blocks. We told about the this ventricular septal device, that device, and you said about the view. So one of the options is to do the rigid bronchoscopy, the right system, treated system, and also use of the topical treated as well as the inflammation movement of the just have fistula surgery doesn't fistula, rectal fistula, what we do? The last tissue should be the right or fulgurated. You can use the laser, you can use the episode, you can just use the monoclonal artery, or you can use pneumonectomy. In certain scenarios, they even use the alcohol. There are smaller cells, but there are just historical moves. Rigid bronchoscopy, do that every laser cognitive or application optical agents so that it provides even fistula, fistula long, so that the infiltrate should be destroyed and we will reapproximate the capabilities. Thank you. So because there are any questions or
ಈ ಸೈಡ್ ಆಪರೇಷನ್ ಇದೆ ಈ ಸೈಡ್
left side में करना है पूरे revisions already 7 है वो just like behind 7 days में आया you are planning on very short period then you do it at the same moment to the same side then you will mechanical failure staple वाला सर reportedly whatever you social government में वो this staple fail work ये हो but if you late fistula for 20 days process में then से reason endocrine तो why is going already within 7 days before this will be sent in their other
तो उसने ऑन टेबल कर दी फिर रिएक्ट कर रहा है ऑन टेबल कर दी मैं तो
Thank you. They like close your possible.